good afternoon to all. First of all, thank you to all the participants for joining us in this webinar. Welcome to the KNCV webinar entitled Changing the Mindset, Advancing DRTB Preventive Treatment or DR TPT and Non-Sputum Testing. So allow me to briefly explain our title, Why Changing the Mindset? This is because, first, many of us are still fixated on giving treatment only to those with active disease, not giving the needed attention to those who are infected with TB who have the risk to become active. Studies show that we will not be able to end TB by just focusing on treatment or treating those with disease alone. Hence, WHO has strongly recommended the RTPT using 6 months levofloxacin for contacts of MDR or RTB. Second, many of us believe that sputum is the only specimen for bacteriologic TB detection. WHO has recommended stool, a non-sputum specimen for the detection of TB among children and young adolescents of less than 14 years old. This webinar is thus opening our minds to innovations in order to achieve a TB-free Philippines. So, I am Annalyn Chodoro, the project coordinator of ASCENT-DRTB project of KNCV, and I will be your moderator for today. So this webinar is divided into two programs or two parts. The first is on the DRTB preventive treatment, and the second part is on stool-based testing or LC-NAAT. So to start our program, let us put ourselves in the presence of the Lord. Dear Lord, we thank you for gathering us all today. We ask that you bestow your guidance and blessings upon each attendee. May we honor one another by keeping an open mind and listening with an open heart. Help us to engage in meaningful discussion. Grant us wisdom and grace to use our talents for betterment of others. May an innovative mindset inspire us to lead with a zealous spirit of service. Continue to remind us that all that we do here today, all that we accomplish, is for your greater glory. We ask this in your name. Amen. Dear Lord,
Mga kababayan, ang pambansang awit ng Pilipinas.
Bayang magiliw, pelas na silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupig, di ka pasisikin. Sa dagat at bundok, sa simoy at sa langit mamahaw, may dinagang tula at awit sa paglayang minamahal. Ang kisap ng watawat mo'y tagumpay na naglilingling, ang bituin na tarong na kailan pa may di magdidilim. Lupa ng araw ng walhati pagsinta, buhay ay langit sa piling mo. Aming ligaya na pag may mga api, ang mamatay ng dahil sa'yo.
okay, to give the welcome and opening remarks, I'd like to call on Dr. Mansa Mabenga. Dr. Mansa is a medical doctor and serves as the team lead for the programmatic management of drug-resistant TB team in KNCV. He provides regional and country technical assistance in drug-resistant TB, including Unitaid's ASCENT-DRTB project. Let us all hear from Dr. Mansa. Dr. Mansa?
Yeah, Annalyn, thank you very much for the introduction. So, good morning and good afternoon to everyone who is joining this virtual meeting. in celebration of the World TB Day 2026. So we have a pleasure to have you all on this meeting. And on behalf of KNCV Tuberculosis Foundation, it's my pleasure to welcome you to this important session on changing the mindset, with a focus on DRTB preventive treatment and non-sputum stool-based testing. I'm sure that today's program brings together global and country experts from the WHO, the Philippines, and other partner organizations to share experience, evidence, recommendations, and early implementations lessons learned. So we are looking forward to having a rich discussion that will help advance more accessible patient-centered approaches to the RTB prevention and diagnosis. So I'm very sure that today's webinar will give us more information, experience, and a way to support and improve the access to DR TPT and also child-friendly diagnostic testing. Thank you very much.
Thank you, Dr. Mansa, for your inspirational words, for encouraging us to be patient-centered in approaching TB treatment and prevention. So, to discuss the WHO evidence and guidelines on DRTB preventive therapy, we have Dr. Avinash Kanchar, a medical officer of the WHO Department for HIV, TB, Hepatitis, and STI in Geneva. He has contributed to several WHO policy documents, latest being the Guidelines on TB Preventive Treatment and the TB Infection and Prevention Control Handbook. Dr. Avinash Kanchar, you may have the virtual floor, please.
Yeah, thank you very much. Please confirm if you hear me well, and now I'll be projecting my slides if you see them. Do you hear me well?
Yes.
And you see my slides as well?
Yes. Yes.
Okay, thank you very much. And thank you for the opportunity. And I bring greetings from the WHO Department of HIV, TB, Hepatitis, and STIs, which is a new department that was formed after merger recently. I'm tasked to talk about the drug-resistant TB preventive treatment. And okay, so let me start by reminding ourselves the commitments from the member states at the UN high-level meeting in 2023, where we wanted to provide TPT to 90% of individuals who were eligible among both people with HIV as well as the household contacts. And this is where we are. We are progressing better among people with HIV, but among the household contacts, we are still far away. In the latest report, it was 25% coverage compared to the 90% that we hope to achieve over the next year. So this is a major gap, and the gap would widen when we talk about MDR TPT. But this is the extent of the gap. Again, this has been the trend, and what we can note is recently over the past few years we have seen some coverage increase among the household contacts. Over the past decade, there is like 5-fold increase in TPT coverage overall, but we see some momentum for contacts very recently over the last 3 years. So the burden overall, we are aware we have a large burden of MDR TB, rifampicin-resistant TB globally, which has been declining, but the decline had been slow. Last year, we are close to 400,000 people who were expected to have MDR rifampicin-resistant TB, and four countries contributed more than 50%, and this includes the Philippines as well. Um, Overall, what we also know is there is a massive gap in reaching people who have MDR-TB. Less than 40% of adults, and among children, the gap is even greater. So this is for MDR-TB diagnosis and treatment, but this would translate also in reaching out to the contacts of people who have MDR-TB and who have very high risk of um, uh, becoming MDR-TB in future. So this is where we are. For TPT, you are aware WHO had been providing guidance on TPT overall for decades now. But for drug-resistant TB, we had been a bit slow, and the reason being lack of global evidence. And if you have followed pre 2018 consolidated WHO guidance, we actually only talked about close monitoring of contacts, and there was no recommendation around TPT. But in 2018, there was an acknowledgement that TPT can be considered among the contacts who are exposed to drug-resistant TB. There was some observational studies around the time. There was some meta-analysis which showed protective efficacy of some of the treatment regimens. So we started to encourage countries to consider TPT among this group, but we didn't have really a clear suggestion on the regimen to use. This was true for the next few years. The recommendation remained conditional. There was a hint of levofloxacin being a likely regimen, along with ethambutol and ethionomide, because that was what was the evidence at the time. Uh, we were still awaiting data from TB Champ and Wequin, which were going on at the time. It was in 2024 when we could review data from these monumental trials, and we issued for the first time a strong recommendation on use of levofloxacin daily for 6 months. So I would just go a bit in depth on the evidence base and try and address some of the frequent questions that we get around TPT implementation among people who are exposed to drug-resistant TB. And this is a glimpse of the TB CHAMP trial. You may be aware it was a phase 3 cluster randomized control trial in South Africa. It covered 6 provinces, and it completed the enrollment in February 2023. The population was largely children and adolescents, and they enrolled about 1,000 individuals. The intervention was levofloxacin 15 to 20 milligrams, maximum 750 milligrams, and children under 5, TPT was offered regardless of eGRAS. And for the older children and adolescents, they considered IGRA positive and people with HIV as eligible. There was 56% reduction in the risk of TB in children who received levofloxacin. And you can see the numbers on the screen. However, the hazard ratio was not statistically significant, and the trial did not really meet its pre-specified superiority threshold, meaning it wasn't clear from these results that levofloxacin is superior to the placebo. And I'll mention in a bit what was the implication. So going on to the Wequin trial, which was again a similar trial in Vietnam, but the focus here was adults more, there were few children, and all of them were household contacts. Um, the enrollment was more than 2,000. The intervention again was similar, 750 to 1,000 milligram per day for 180 days. But the eligibility here was positive TST. So all the people who received TPT had an test positive. And in this study as well, there was 45% reduction in the MDR-TB risk in adults and adolescents. And again, if you see the numbers, there were six TB cases amongst the in the levo arm versus 11 in the placebo. However, the relative risk was again not statistically significant. So looking at both these studies, you will note individually both these studies they had a signal of protection with levofloxacin. However, on their own, the difference between the two arms was not statistically significant. And during the post hoc analysis, it was noted, and when it was presented to WHO also, that the presumption in the sample size calculation was the placebo arm would have higher TB compared to what was observed in these trials, and that's why they were not powered enough for the result, but both the trials showed a signal in a same direction. So, but at the same time, during conduct of these trials, both the trialists were in constant contact and they were interacting because they were testing a similar regimen, similar drug formulations, and it was decided in advance before the data were looked at that they would do a joint analysis, and they ended up doing an individual patient data meta-analysis, which helped both increasing the you know, confidence in either of the trials. If you see the weak-win Bayesian analysis and the TB-CHAM Bayesian analysis, you will note both show a statistically significant difference compared to the placebo. And overall, as well, we see 8 TB cases in the levo arm compared to 21 in the placebo arm, which is like 60% reduction. And this Bayesian approach, which was developed by the MRC, it actually helped increase the confidence in either of the trial. They could borrow some of the information from each other, and that increased the confidence in the results. And this was presented to WHO, and the WHO guideline development group considered this to be a moderate level of evidence, and issued a very strong recommendation on use of levofloxacin. So the recommendation text reads: in contacts exposed to multi-drug or rifampicin-resistant TB, 6 months daily levofloxacin should be used. And the target population was the household contacts, the close contacts, or bacteriologically confirmed drug-resistant TB cases. And the priority populations included the children under 5, people with HIV, individuals who are immunosuppressed, and also people who test positive on a test of infection. For levofloxacin, the key advantage is it's oral, it's once daily. There are no significant HIV-ART interactions, so it can be given in people with HIV. It was deemed to be cost effective. There was some cost effectiveness data that was reviewed by our guideline development groups as well, and it was overall very safe in children. There were no cross resistance issues, so the treatment options were not curtailed for future in case of a breakthrough TB. So there were several key advantages, and However, as for any other TPT, the prerequisite is ruling out the disease in advance, and same for this group, along with confirming the drug resistant status of the index case, as well as considering fluoroquinolone resistance testing if it's available. Um, and what is important to note is that there is no drug adjustments required with DTG or other ARVs that are currently being used. And for children, there is really no need to test, as the trial itself was done in children, irrespective of the test results. However, there is a limitation in this recommendation. It doesn't cover the pre-XDR contacts, meaning levofloxacin or quinolone resistant individuals. So, moving on to the safety of the regimens, and as I said, overall observation was the regimens are quite safe in children, and to know what we see on the slide is. We need to keep in mind Weekwin was largely adolescents and adults. TB Champ was in children. And when you see the grade 3 or above adverse events, and what we see is overall there is no difference between the levofloxacin group versus the placebo group. Um, and all in the grade 3 or above adverse events related to the study drugs, we see 14 events in overall in the levofloxacin group and 10 in the placebo group. And again, this was not statistically significant. So compare. But if you see in the Weekwin trial, which is in adults, the people in the levo group had 5 times more grade 3 or above adverse events. So at the individual trial level, we see a difference, and meaning the regimen is less well accepted by in adults, but in TB in children it is quite safe. And similarly, in grade 3 or above serious adverse events, there is no real difference compared to the placebo arm. Discontinuation with levofloxacin, again, overall, what we see is among adults, the discontinuation rates are quite high. And this is significant. In children, though, the confidence intervals overlap, and so it's considered not significant. The most adverse events that are seen most often are musculoskeletal events, and again, it's more in the adults, and comparatively, children tolerate it better. So overall, what we can conclude is levofloxacin is well tolerated in children. The most common adverse events, a large proportion of individuals would get, particularly in adolescents and adults. 1/3 patient may have dizziness, headache, nausea, abdominal pain, which can all be managed clinically. Musculoskeletal events as well, more in adolescents and adults, mostly grade 1 and 2, which can be managed clinically. Serious adverse events are very infrequent, only about 1% grade 3 or above adverse events, which were not statistically significant compared to the placebo arm. And treatment discontinuation as well is uncommon. So looking at the dosing, and you can find these table in the TPT operational handbook and on the WHO knowledge sharing platform that I will share a link on this presentation as well. And what you'll note is at the bottom of this table, for levofloxacin, there are 3 formulations. There is a dispersible formulation, 100 milligrams, available as well, and as well solid formulation, 250 milligrams and 500. And you will note we have dosing for all age groups and across all weight bands. So everyone can receive levofloxacin. And what we saw in the latest report, about 50 countries already had some experience of using the levofloxacin, and this included 7 high TB burden countries listed on this small box on the slide, and also the high NDR-TB burden in Eastern Europe and Central Asia. So there is already some experience of using levofloxacin in programmatic settings, and we see positive results from that. As I said, although we have a strong recommendation for use of levofloxacin among MDR TB contacts, and overall it is safe, the formulations are available, we still have a gap in the recommendation. The pre-XDR TB, where the index patients would be levofloxacin or the quinolone resistant. However, we are looking for some data that are likely to emerge over coming years. The delaminid is being tested in the Phoenix trial. Bedaquiline for the TPT option as a pan TPT option is also being studied in the breach TB trial, and there are some observational studies which have recently been reported as well using moxifloxacin. So I'll just mention briefly about the Phoenix trial. It's again a cluster randomized trial, and it's spread across 27 countries. Very large study, more than 3,500 household contacts. The enrollment has been completed. The follow-up is currently going on. And this will test 26 weeks delaminid daily along compared to isoniazid regimens. And we are hoping to have the datas by the end of the next year, and following which we will convene our guideline development group and present these datas. And you'll note it will cover this gap that we have right now. And because it's already used by the programs and the formulations are available, child appropriate formulation are also available. So we should be able to use it across all age groups. The breach TB trial, another encouraging development, and also that fact that bedaquiline is being tested. It's a first trial that is testing universal TPT with 1 month oral regimen that protects both drug resistant and drug susceptible forms of TB. And it's funded by Smart for TB project. The enrollment started last year, but the results are likely to be available only late 2028, early 2029. And it's a multinational trial, so we'll have broad base of evidence from low middle income countries. The target populations here as well, household contacts, both drug resistant and sensitive TB, people with HIV, children of all ages. There's a plan to also include long-acting injectable bedaquiline as the knowledge and understanding expands. So, and again, like the previous slide, this drug, since it's been used for a long time, the safety profile is established, so it can quickly be taken up for programmatic implementation. So we are hoping to have both these products, the data from these studies available to the WHO, but we foresee the Phoenix data to be considered earlier, and we'll have some recommendation over the next couple of years. I just wanted to touch on two important aspects before I close. TB screening is really critical for in starting TPT for India TB contacts, and this again is an algorithm that I draw from our operational handbook. And the boxes here emphasize the need for thorough symptom screen and also use of tools like chest X-ray, C-reactive proteins and rapid diagnostics, like expert in high burden settings, and also the use of the TST and eGRAs, particularly among contacts who are more than 5 years. So for children and people with HIV, we don't push for testing. However, for adults, and as you have seen from the data from the Bequin study as well, adults often face some adverse events, and so it would be important to try and get test for infection done for adults. However, overall, given the protective effect of the regimens that is recommended, and it WHO does say if the tests are not available, we can still continue giving levofloxacin. So for tests for infection as well, we have more progress. We have, apart from TSTs and eGRAs that we recommended before, we have a new test, antigen-based skin test now recommended. We also had a review of data from more eGRAs. There are now 5 eGRAs which are endorsed by WHO, and you can find the names on the slide here. And the antigen-based skin test I mentioned, SIL-TIP-C, it's also available on the GDF catalog, and it costs around $1.50 per test. So this can be now accessed as well. So tests, we have broader range of tests available, and countries should consider budgeting and implementing testing, particularly for adult contacts of FDR-TB patients. And this would be about around the last slides. I have a program for programmatic management of DR TPT. These are some of the key aspects that the program will have to consider. First and foremost, to update the national guidelines, we need to allocate resources, particularly for procurement of the TPT regimens. Although the adult formulations are quite affordable, the disposable formulation for children are still quite exorbitantly expensive, and there would be a need for some market shaping work around for that. The programs will have to obviously work on the capacity building aspect, implementing strict protocols for TB screening, baseline evaluation, and then identification of all the contacts in the household, systematic listing, ruling out TB disease. That this cannot be underemphasized. Test for infection wherever feasible, but even without tests, we should still consider giving TPT for the DRTB contacts. Another issue is about DST for the source cases, fluoroquinolone resistance. It's desirable to test that, although we don't have an alternative TPT option right now, but it's important to follow these protocols wherever feasible. Baseline assessments to rule out the contraindications, as many of the adults do face some issues. We need to focus on this as well. Regular follow-up would be important, adherence monitoring, and as well also monitoring and management of the adverse events promptly. So these are some of the programmatic areas that we'll have to consider, and I'm sure when the national guidelines gets updated, these are the elements that would be addressed. So I just want to also draw your attention to a mobile application that WHO had developed a few years back. It's available for countries to use. There's no license involved, and we have been updating it over the past few years, including capacities to monitor adherence as well as adverse events. So you can consider this, and finally on the knowledge sharing platform I mentioned, you can find all the guidelines, latest guidelines on this blue tab that is being shown, and also there are the operational handbooks as well. So I would like to close by acknowledging all the individuals on this slide, and I thank you and happy to take questions. Oh.
Thank you, Dr. Avinash. So just a few takeaways. Thank you again for giving us a glimpse of the Phoenix and the Bridge TB trial. Of course, we have the VQueen and TB Champ as a basis for the guidelines here in the Philippines, and sharing also with us the new antigen-based skin testing, and enumerating the programmatic implementation, the health cost in the Philippines. So, for questions, we will reserve the questions at the later part of this part one session. So, if the participants have question, kindly just put it in the chat box. Let's park it for a while and let's move on with the next presenter. So, as we have heard from Dr. Avinash, that WHO has strongly recommended preventive treatment for MDR-TB. So, from the global guidelines, let us now move on to the country implementation. To discuss the Philippine experience in engaging stakeholders for guidelines development, I'd like to call on Dr. Charis Malbasias, who is currently the OIC Division Chief of High Burden Infectious Disease Prevention and Control Division of the Disease Prevention and Control Bureau, or DPCB, of the Department of Health Philippines. Dr. Malbasias.
Yes, thank you, Ma'am Anna, and thank you for the KNCV for this opportunity to share our experience in terms of the guideline development for the DR TPT. So to start, the Philippines, no, I'll just like to first provide context of what we are as a country and our burden. So in 2024, based on the WHO Global Tuberculosis Report, we we are third globally in terms of the contribution to the global TB cases. And in terms of MDR-TB, we are still third, no, at 7.1%. So the introduction of the drug-resistant TPT is really a good news for us. In 2024 also, no, to just contextualize also in terms of the burden, while we are third based on the WHO estimates, we are still just notifying 25% of our estimated cases. And in terms of TPTs for drug susceptible TB, the red line shows our target from 2020 to 2023 and our achievement in terms of enrollment. So for both notification of drug-resistant TB and TPT, there is still a lot of things that we need to improve on in terms of our health system for us to achieve this notifications and enrollment targets. However, if we break down the TPT enrollment targets by the target population, we are actually good in terms of the target population of people living with HIV. The orange line is the target, so the blue line shows that we are above target in terms of PLHIV. However, in terms of household contacts, either children less than 5 years old or those above 5 years old, we are still below target. So these are our pain points, the household contacts. In terms of guideline development in TPT, We have started our first guideline on TPT in 2008 with the EO 2008-0022, and this guideline just provides the isoniazid preventive treatment for people living with HIV, so, with no active TB. So that's the only population that is being provided with TPT back then in 2008. In 2014, that's when we have expanded the population to all household contacts of under 5 years old of a BCTB index case without active TB, based on signs and symptoms and chest X-ray findings. For those household contacts that, of clinically diagnosed TB, we are also providing TPT in 2014, but only for those with positive PST. So for the development after 2014 is the sixth manual of operations. So this time, we have further expanded the eligibility to TPT to above 5 years old of a BCTB index. And we have also mentioned certain risk groups. We have also provided guidelines. So not only IPT already, but also the other shorter treatment regimens such as the 4R, 3HR, and 3HP. And then in 2024, we have just provided an additional guidance on the TPT regimens for PLHIV, specifically on those under the TLD, just specifying that one of the key specifications there is that when they are on 3HP, they don't need to adjust the dose of the dolutegravir. So those so far are the guidelines that we have on TB preventive treatment. And then in 2025, because of the WHO recommendation for TPT for household contacts of drug-resistant TB index, we have decided to include it in our strategy. In 2025, fortunately, it was just in time when we are developing our new national strategic plan, which we call the Philippine Strategic Elimination Plan Phase 2, 2025 to 2030. And the vision, mission, and goal of that plan is to have a TB-free Philippines with zero TB deaths. And this vision, our goal is to reduce by 2030 our incidence rate, or our incidence rate from 643 to 300 per 100,000. Our TB mortality rate from 18 to 5 per 100,000, and catastrophic cost from 42% to 0%. And for us to deliver this goal, we need to provide the following service delivery objectives: to screen 10 to 13% of our population, test 2 to 3% of our general population, which is equivalent to 100% of our presumptive TB, and detect 90% of our incident TB cases. We also need to successfully treat 90% of our notified TB cases, whether DR or DSTB, and provide TPT to 75% of our eligible household contacts. We do acknowledge that the international target is actually 90%, but for TPT, however, given our very low accomplishment in the baseline year, when we modeled it with the WHO. This one is the more realistic goal given our context. And then for us to deliver these service delivery objectives, we have outlined in this field step our other cross-cutting objectives, which includes having a resilient health system, an enabling health system, and having a good social behavior change and communication plan that will promote early health seeking and positive healthy behaviors. So in numbers, this is it. No? So we just want to highlight how many are we projecting to find, or are we targeting to find in terms of drug-resistant TB. So we highlighted this because based on our DR TPT guidelines, we will be targeting those indexes. And then for TPT, this one is our target. Although acknowledging that when we did this modeling, this one is just for drug susceptible TB when we did this modeling back then. So I will zero in terms of what we outline in our strategies in terms of prevention, and the DRTPT falls in the number 14, no? New clinical algorithms for TB preventive treatment. And we also have a very special section for MDR-TB in our field step 2, and in the cascade of prevent, we have specified there the TPT among household contacts of DR-TB and introduction of the TPT regimens for DR-TB contacts. So thus the reason for our immediate actions in adopting the DR-TPT. So we started in June in the establishment of our core group members. So it's very important to select a task force or core group member that will provide their expertise in the development of the guideline. And with the help of KNCV, we were able to organize this group. And we had a total of 4 to 5 task force meetings as we developed our interim guidelines. So what we had issued in September last year is the pilot implementation guideline, the interim pilot implementation guideline. We have this one, we have selected advanced implementation sites to implement the DRTPT. And as a body, we decided to do that because we wanted to understand first the operational details that we need to include in a programmatic guideline. So in that pilot implementation, we also saw what should be present in our health facilities and the competencies that needs to be that our health workers need to have when we implement the DRTP. So currently we are at our pilot implementation phase, and next week we will be, or within this week, we will be reviewing the data that we have so far in terms of pilot implementation, and proceed with now starting reconvening our task force to develop the nationwide policy on the RTPT. So aside from the task force meetings, we also have regular meetings with the pilot sites to help address the operational issues that they are encountering. So after by second quarter 2026, we will be developing the nationwide policy and will hold subsequent stakeholder consultative meetings, and hopefully by third quarter 2026 we will be issuing the policy and start doing the capacity building for the rest of the country and have it fully implemented by that time. So one of the facilitating factors or critical element in our guideline development is the formation of our DR TPT task force. And the DR TPT task force, its deliverable, their deliverables is the policy development and the implementation plan. So our DRTPT task force is a combination of different experts. So we have our experts in laboratory, we have our experts in terms of the guideline development, on programmatic implementation. We also have clinical experts for both children and for adults in terms of TB. And we also have with us the WHO to help us also understand the nuances of the guidelines and also the KNCV, so which because of the expertise of Dr. Mamel particularly, she was able to lead us in our discussions and also on some of the issues that needs to be further fleshed out. So the functions of our DRTPT task force is to review related literature and provide inputs during meetings and consultations, to share relevant data, resources, and tools to support the policy development, formulate policies and draft an advanced implementation plan, consult relevant stakeholders, including representatives from the patient support groups, finalize the policies and implementation plan for initial operations, which guided our advanced implementation sites, and serve as resource persons during the advanced implementation. So during the advanced implementation, we had also a series of capacity building, and one face-to-face. So the task force are there as well to provide guidance and to be resource people as well in our sessions. So in our policy, we have outlined we have delineated or provide guidance on the roles of our different stakeholders. It's very important when we are starting out a new policy to provide guidance on the roles of our stakeholders. So for the DPCB, which is our bureau in the Ministry of Health or Department of Health Philippines, this is our main accountabilities to lead the development and assurance of interim guidelines specific to the pilot implementation of the RTPT, develop and roll out a training aligned with the standards, and do the monitoring and evaluation and ensure the allocation of supplies. We also have what we call the TB Medical Advisory Committee, which provides expert guidance to our primary care facilities in terms of difficult cases and managing adverse events. And then for the Epidemiology Bureau, they are in charge of the surveillance and also of ensuring that they work together with our knowledge management and information technology service to ensure that our indicators that we have outlined in our policy that will be monitored is included and gathered and analyzed. And then the Health Promotion Bureau is very critical in terms and also to lead the social and behavior change communication campaigns to promote acceptance, uptake, and adherence to TPT. So at this month we will have a workshop with them so that when we do the nationwide implementation of the DR TPT, the materials are ready already. So KIMIT is in charge of our information system, and then the NTRL or National TB Reference Laboratory is in charge of our on providing technical guidance on the laboratory testing protocols and providing quality assurance of our rapid TB diagnostic laboratories. And then our sub-national offices is in charge for the direct oversight and supervisions of our primary care facilities. That is part of the advanced implementation. And then, of course, the LGUs that are part of the advanced implementation should adhere to the interim guidelines for the DRTPT implementation, and they are required reporting that they need to accomplish and submit to CHDs in a timely and accurate manner. And then our development partners, KNCV, Global Fund, and the U.S. Department of State PACNES is also there to provide technical assistance, the WHO, to strengthen national and local capacity, and then support resource mobilization. So some of our needs are still being supported by Global Fund, like the XDR cartridges, some of the PPD, and also the use of striders and the chest X-ray vouchers. So what are the country lessons in this at this point when that of our implementation of the DRTPT? So first, an assessment or checklist is important in our initial site selection, which our partners know were very critical in terms of developing it. So in that through that assessment or checklist, we were able to determine the sites that are already ready to do the advanced implementation. Aside, of course, from their enrollment, so the first filter is the facilities that have high enrollment of DRTB patients, but the next would be if the facility is ready to handle the DRTP. So we have this checklist that helped us, and then important also is the collaboration with different stakeholders, which I've mentioned. That is part of the policy. And each partner has their own strengths that contribute in a unique way to guideline development. It is in the task force meetings that we discuss the different contentious issues that where we do scenario building as well. What if this health facility encounters this challenge? And it helps to have this different perspectives from the hospital side, from the local government unit side, from the region side, the subnational side. So all of these perspectives helps in creating a very evidence-based and context-based guideline. And this helps us also have answers before the consultation to a wider stakeholder. So in the stakeholder consultations, some of their questions have actually been discussed already in the task force. So it's easier for us to 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 convince our advanced implementation sites in adhering to our guideline. And then number three is in any advanced implementation is to expect operational issues. But what is critical is to have that platform where these operational issues uh, is discussed, and there should the monitoring, the regular monitoring that is being conducted is important. That will be that's where the issues will be that's the jump off point where these operational issues um, are discussed, and we have also clear rules in terms of our policy on how to address this operational issues. So, so that's it, no, for our country experience, and thank you so much for listening. Over to you, Anna.
Thank you, Dr. Malbashas. Thank you for giving us the experience or the inception of the Philippine guidelines for DR TPT, and emphasizing the importance of assessment, having assessment or checklist, and of course, collaboration with partners and being open to operational issues. So, we have heard from Dr. Charisse Malbashas on how the DOH has convened the DRTPT task force to create the national guidelines for DRTPT. So, to discuss the early lessons of the advanced implementation of the DRTPT in the Philippines, I'd like to call on Dr. Mamel Kelapio. Dr. Mamel Kelapio is an infectious disease specialist, and she serves as the consultant of KNCV. She is the country lead for Unitaid's ASCENT-DRTB project, and she also supports the NTPs in the programmatic management of drug-resistant TB. Dr. Kelapio?
To thank you all for attending this webinar. Always thank you also for our previous two presenters. We're fortunate that we have WHO to always guide us in our technical issues and new implementation strategies. And of course, thank you also to DPCB for allowing us to collaborate with you. So I'll be talking about the advanced implementation of the RTPT in the Philippines and the early lessons that we've had. So how do I? It's not moving. Okay, so in the two previous presentations, you have heard about the global guidelines as the WHO consolidated guidelines, and it comes with an operational handbook. This came out in 2024, where WHO strongly recommended the contacts exposed to MDR-TB to be given 6 months of daily levofloxacin as preventive treatment. And you also see here on the right, the national guidelines, which is an interim guidelines for DRTPT in the Philippines. And as you heard from Dr. Charisse, this didn't just come easily. This was a product of several months of meetings and consultations through the DRTPT task force that was convened by DPCB. Next slide. So next, please press. Yeah. I'll not go through this because this has been shown by Dr. Cha. The Philippines is a high burden country, not just for MDR-TB, but also for TB and also for TB-HIV. And it ranks third in TB burden globally, contributing to 55% along with other countries, along with 4 other countries in the world. And for MDR-TB, it's also number 3, contributing to more than half of the global MDR-TB burden, together with 3 other countries. Next slide. And so it was very timely that in 2025, Unitaid provided support to allow us to pursue our guidelines, our interim guidelines for the advanced implementation of DR TPT in the Philippines. So what I'll be sharing are preliminary data. So these are data that we have gathered from June 2025 to March 2026 from 18 advanced implementation sites in the Philippines, distributed in 7 regions all over the country. So you can see on the right, the regions that were engaged for DRTPT. And I'd like to take this opportunity. Some of them are in the audience, in the online platform. Thank them for their participation in this pilot project. Next slide. So I'd like to go through this cascade of care, which is the approach that is recommended by WHO in terms of the RTPT implementation. So step 1 is contact investigation. Step 2 is screening to rule out TB. Step 3 is testing for TB infection. And step 4 is initiation and completion of the RTPT. So I'd like to go through each one of them. Next slide, please. So for the first step, it's contact investigation. So of course, before we talk about contacts, we have to identify the index cases. So the index case for DRTPT is an MDR-RRTB patient who is fluoroquinolone susceptible. Fluoroquinolone susceptible because we are using fluoroquinolone for the preventive treatment. And the household contacts should be contacts of the fluoroquinolone susceptible MDR-RRTB index. Next. So we were able to identify 190 index cases from June to March. So they were MDR-RRTB, fluoroquinolone susceptible, and those 190 had 503 household contacts. So that gives us an average of around 2 to 3 household contacts per index. So the standard is, once you have an index case, then you identify the contacts, household contacts, and then you collect their information, their names, the demographics, and other details. And for ASCENT, for this project, even at this early stage of the cascade, can look on the right. So we had 503 household contacts, only 481 or 96% had proper registration. So the rest of the 503, the 22 or 4% at this stage were already lost. So they were unregistered, there were no patient information. And so the possible reasons for this are documentation was missed by the facility, or simply the patient or the index refused to share household member details. Okay, so of our 481 household contacts with proper registration, we had 7% children, those were less than 5, and the rest, majority, were 5 years and older. Next slide. So step 2 is screening to rule out TB. So how do we do this? So for the Philippines, our guidelines recommend symptom screen and chest X-ray. Next. And so the standard is for all ages, all contacts should be screened for symptoms, and only for the 5 years and older, they need to have an X-ray. So for the project, this X-ray is for free through the Global Fund. So there are vouchers that are given by PBSP to household contacts for them to have free radiology. So in our project, at this stage of the cascade, you can see that at least 18% of our 34 children, those who were less than 5 years, were not symptom screened. So that is already, again, a loss. And for those who are 5 years and older, at least 24% or 109 did not have a chest X-ray for one reason or another. So you can see on the right that these are the symptoms that are in the manual of procedures. So we have clear symptoms to look for in adults and symptoms to look for in children. So the reasons for this missed opportunities. So those that were not symptom screened and those who had no chest X-ray were the limited clinic hours of the facilities. Most of our contacts were students and belong to the working population, and therefore they would be free when the clinics are already closed. Another reason is the financial constraint for contacts to go to the facility or to go to the X-ray facility. Next slide. So why do we need TB screening? Actually, why do we need to rule out TB? This is actually a very critical step in the cascade because giving TPT to a patient who has disease is actually tantamount to giving a patient one drug or just levofloxacin. So we really have to rule out TB in these patients, in these household contacts. Next slide. So the next step after we have identified the contacts and then ruled out active disease in them, the next step is to test for TB infection. So what do we use for that? We use TST or tuberculin skin test or IGRA. Next. Okay, so the standard is to do TB infection testing for those who are 5 years and older without risk factors. What are the risk factors? It's on the right. The risk factors are HIV or other immunosuppressed state, diabetes, smoking or malnutrition. Exposure to more than one index case in the household is also a risk factor. So for patients who have any of those risk factors, these contacts need not have TST. So if you look on the blue box, these are the patients who need not be tested for TB infection. Those who are less than 5 years old, and as I said, those who are 5 years and older with risk factors. So only those who are 5 years and older without risk factors will need a TB infection test. Okay. So in our project, there is a lot of loss here in this part of the cascade. So at least 28%, so that's around 79 of those who were eligible to have a TST but did not get a TST. And there were at least 3 patients who did not come back for TST reading. So they were given the injection, but they didn't come back for reading. Another finding that we have is that we had a very low TST positivity. It was only 15%, no, it was 25% of all those that were given TST. This is very low compared to what is written in literature, that in high burden settings, it's at least 40% TST positivity. And for adults who are household contacts of index cases, it can reach up to 65%. So what are the reasons for these missed opportunities? Why didn't they have TST? Why did these 3 patients not have TST reading? So one of the reasons is that if patients are working or if patients are studying and the clinics close by the time that they're free and they need to visit twice, then it's really a challenge. So that's one of the reasons. That's actually the most common reason. Sometimes there's also TST unavailability. That's why some of these patients didn't have TST. So here's the limited clinic hours, and there's financial constraint. Patients need to go to facilities, and so they have to shell out money out of pocket to go to the facility for the TST, and also for the screening for chest X-ray. Next slide. So the other challenges of TST actually is that it's not as reliable as IGRA. As I mentioned, 2 visits are required. Training is required of the staff, and cold chain is required for the storage of the TST vials. And as I said, it gives low positivity. So there was variability among all the clinics. Some clinics didn't have any positive patients. So it was 0 positivity in some of the clinics. And shortages are also happening. For IGRA, it's not widely used and it's expensive per test. However, numerous studies have indicated that IGRA is more cost-effective than TST for the screening of TB infection, especially in high-risk or BCG vaccinated populations. Next. So just to compare TST with IGRA, the specificity of both is generally high. It ranges from 95% to 99%, but both vary in sensitivity. So the sensitivity of TST is lower than IGRA. It's 60 to 81% based on the different induration thresholds. And the lower sensitivity is due to the cross-reactivity with BCG, the vaccine. And it can be affected by immunosuppression. So it gives a weaker, a negative reaction to the test. IGRA sensitivity, on the other hand, is higher. It's 81 to 90%. This is a pooled sensitivity across different IGRA tests. But likewise, it can be affected by immunosuppression. Next slide. So the last step in the care cascade for DR TPT is the initiation and completion of DR TPT. And as we saw in the recommendation, 6 months of levofloxacin daily is recommended for contacts of MDR-RRTB. Next slide. And so the standard is, once you have ruled out TB in the household contacts, then the patient may be eligible for DR TPT. So for those who are less than 5 years old with no signs, TB signs and symptoms, that's enough for us to allow this patient to proceed to DR TPT. For those who are 5 years and older with risk factors, we just need to have no signs and symptoms and negative X-ray, no need for TST. But for those who are 5 years and older without risk factors, we need no signs and symptoms, negative X-ray, and a positive ST for IGRA. So that's the current policy now in the Philippines. So what did we find in our project? So we found that there was hesitancy among private physicians to adhere to the guidelines for DR TPT. At least 5 household contacts were advised to stop DR TPT by their private doctor. At least 3 household contacts were advised not to be evaluated for DR TPT. And second, patients themselves or parents of children refused to have DR TPT. Is 24% or 8 out of 34 of those children were not given TPT because the patients refused. The parents refused. Next slide. So we have gone through the different steps in the cascade. So just to summarize, in the first step of contact investigation, at least 4% had no proper registration, and so these patients were already lost. For step 2, screening to rule out TB by symptom screen and chest X-ray, 18% were not screened by symptoms, 24% did not have an X-ray. For step 3, testing for TB infection, 28% did not have TST, and 3 patients had unread TSTs, and 15% it was 15% off the TST positivity because it was only 25%. And the minimum expected TST positivity in a high burden country is 40%. And in the last step, 18% were not screened and 24% with no X-ray. So you can see, next slide please, that there are considerable lost opportunities in the entire care cascade for DRTPT. And we look back at the reasons for non-adherence using the WHO non-adherence framework. So there are factors that are health-related, healthcare systems related. There are socioeconomic factors, test-related factors, patient-related factors, and condition-related factors. And I'll go through each one of them. Next slide, please. So for the healthcare systems related factors, most of our challenges actually fall under this category. So there was lack of awareness among health staff, especially physicians. There was unavailability of TST. There were shortages of cartridges, expert MTB, XDR to rule out fluoroquinolone resistance. The clinic hours are limited and the services are centralized. Our suggested solution is to come up with IEC materials that are evidence-based to be circulated to healthcare providers, especially physicians. We need to prioritize TPT in the program. We need to have better quantification so that we don't come up with shortages. And then we need to adjust our clinic opening hours so that patients who are working or students will have the time to visit the facilities. And we also need to decentralize services. Next slide. The socioeconomic factors. This refers to the financial barrier experienced by patients for facility-based services. So what do we need so that patients don't have to go to the facilities? We need community-based or home-based approaches. So there are telemedicine platforms that are now being implemented in countries, and this can serve to bridge the gap between the contacts at home and the TPT services that are based in facilities. Test-related factors, next slide, please. Lack of TST reliability, lack of availability, and also low program utilization of IGRA. So we need to review our policy on the test to use or to the population that need TB infection testing, review the mandatory use of TB infection testing, or shift to more sensitive options. So next slide. For patient-related factors and also for the inherent lack of symptoms in TB infection, the usual question is, why do I need to take this drug for 6 months when I don't feel anything? So we need IEC materials also targeting patients, families, and communities. And we need to engage civil society and survivors to help us advocate for TPT. Next slide. So in summary, and these are the next steps, we need to change our mindset from focusing only on treatment of patients with active disease for DS and DRTB, or to do TPT only for DSTB. We need to expand our attention to treating those who are infected, and not only for DSTB, but also for DR patients. So the data show that there are many lost opportunities along the care cascade for DRTPT that can be addressed for DRTPT to provide the desired impact. So next step would be to do a data review and consolidate all our lessons that we learned during this advanced implementation and revise the interim guidelines for nationwide implementation. So those are the things that we need to do. So thank you very much. I'd like to say a special thank you to our advanced implementation sites, the household contacts, the Centers for Health Development, our regions, the health facilities, and of course, the NTP, DPCB, NTRL, and all our partners and stakeholders. Thank you very much. Back to you, Annalyn. Thank you.
Thank you. Thank you, Dr. Calapio, for giving us the early lessons of the advanced implementation of the DR TPT in the Philippines and the importance of having a change in the mindset and the paradigm shift in addressing the TB concerns of the country. So from Dr. Mamel's talk, we learned how some of the steps in the care cascade can be a barrier in DR TPT. To share a local experience on TST as a barrier to TPT, let's give the floor to Dr. Stoban Calon. Dr. Stoban Calon is a public health specialist with nearly 2 decades of experience across Asia and the Pacific region. Dr. Calon worked with governments, WHO, and global partners across multiple countries, bridging frontline operations with strategic advocacy and health policy reform. He has held senior leadership roles with MSF and concurrently serving as the advocacy coordinator in the Philippines. He leads the national level policy engagement, civil society collaboration, and access to treatment initiative. Dr. Calon, the virtual floor is yours.
Thank you so much, Annalyn, for the introduction. Are you able to hear me?
Yes.
And are you sharing my screen or I'm sharing my screen?
You can share your screen.
Okay, I have shared. Is my screen visible or?
Not visible yet.
One moment.
Now it is.
Okay, great. Thank you. You can see my slide?
Yes. If you put it in full screen.
Yeah. Is that okay?
Excellent.
Okay, thank you so much. So good afternoon and good morning and good evening to all colleagues wherever you are in the world. And thank you, first of all, to KNCV for giving us the opportunity to present the work of MSF in Tondo, Manila, where we are implementing a community-based active case finding program with linkages to care in collaboration with the Manila Health Department. So, yeah, I'll first walk you through. So in this presentation, I'm going to walk you through our local experience, where we will make a case for why tuberculin skin test or TST as a prerequisite for TPT is not just a procedural hurdle, it becomes a barrier to providing TPT. So to begin with, of course, you all know how TB spreads, so I'm not going to go into this. And what is TPT has already been explained by the previous speakers. So I'm also going to skip this. So yeah, just to put it in the context, we are in the project that I'm talking about. We are talking about here, and since we were not part of the DR TPT that Dr. Mamel spoke about, we are still doing here TPT only for DSTB. And the TPT options we usually have is 3HR and 3HP. And as the previous speakers have already alluded, I'm also not going to spend much time on this one. So these are the most at-risk groups that we have been hearing from the previous speakers as well. As you know, TPT, it works by eliminating the TB bacteria. before they can cause the active disease. We now have shorter regimens like 3HP, and it achieves two things. It protects the individual and by reducing the active disease in the community, it breaks the chain of transmission. So a little bit about the context that I'm talking about. It is one of the world's most densely populated contexts. It has about 76,000 inhabitants per square kilometer, with very compromised conditions of poor housing and severe overcrowding, affected by widespread poverty, poor nutrition, and actually all the TB transmission conditions are present here in extreme conditions. So about the numbers for you, they speak for themselves. So we are, as you know, in Philippines, the overall country incidence as per the WHO 2025 global TB report is 500,000. But in Tondo setting, among the population that we screen, the general population, it's about 4.2 per 100,000, which works up to 4,200 per 100,000. Which is roughly up to 10 times the national average. And among the age group of 5 to 15, it's about 7.6%. So it's considered one of the highest prevalence among the highest recorded anywhere in the world. So TST requirements as of now, what does it require? As also mentioned by Dr. Mamel before, a nurse has to visit the patient twice, and the patient has to return. There's a cold chain that has to be maintained. And also when a vial is open, all the 10 doses have to be used. So only, as and when it happens. So it's pretty demanding on the patients and the health services, human resources and logistic challenges. So here I would like to present something that might be tell the story how alarming the situation in a context like Tondo is. So among the patients that we screen, in 2025, the rates were 96% positive among those who screened. Yeah, if you look at the average across the years, it was a bit lower, around 88%. So in this kind of with these high rates, we can assume that in this kind of a setting, almost all infection can be assumed for almost all household contacts. This is to just highlight what the testing gap was like. So of the household contacts under 15 years, 5 to 15 years that we try to do TST, we could achieve only 47%. And the challenges I mentioned before, in addition to that, we were also impacted by, during this phase, there were global shortages of TST. There were some stockouts happening as well. And interestingly, there was a low acceptance of TST from the parents of the children that were offered. So currently, as per the 6th edition of the Department of Health Manual of Procedures, TST, as Dr. Mamel was also mentioning, not required for the following conditions, but it is required for all of the household contacts before TPT can be initiated, regardless of local prevalence or TB exposure context. In Tondo, this blanket requirement creates an unnecessary barrier for most of the at-risk population. So what is MSF advocating here for is for 4 things. First, to remove TST as a requirement in a context like Tondo, with up to as high positive rates as we reported, up to 88 to 96% over the years. This positive rate seems to add not much clinical value to do TST. Second, to offer TPT to all household contexts in this kind of a context, avoiding the complexity of screening subgroups. Thirdly, redirect time, personnel, and cold chain resources currently spent on TST logistics towards other more perhaps productive activities like treatment adherence support and contact tracing. As you know, the workforce is pretty stretched out already, and in the midst of all these demanding schedule, they have to perform all these other procedures to do TST that I just mentioned. And fourthly, to align with the WHO guidance, which support offering TST where risk-benefit calculation clearly favors treatment and where TST is not said to be obligatory. So in summary, to conclude, TPT is indeed the cornerstone of ending TB, but TST requirements limits the access to in high burden countries, contexts like communities like Tondo. The evidence is pretty clear with such high positive rates and low coverage achieved due to the various challenges posed by the way we have to do TST. And then, of course, the costs that can be resources that can be used for TST could be redirected to more productive activities. So therefore, the solution is quite straightforward to remove TST as a prerequisite for all household contacts in a context like Tondo. Thank you very much.
Thank you, Dr. Calon. We appreciate your sharing of an enlightening experience on the use of TST in TPT. So, moving forward for the next topic, in Dr. Cha's talk, we heard that in the process of guidelines dissemination, a number of orientations were conducted. In all these orientations, we have taken note of questions that were frequently asked. For the next session on FAQs, I'd like to call on Drs. Rugaiya Calapis or Doc Guy in tandem with Dr. Avinash Kanchar. Doc Guy will say the FAQ and enlighten us with a little background or context of the question, and then give the floor to Dr. Avinash for his technical input. Just a short background of Dr. Guy. Dr. Guy Calapis is a KNCV consultant for ASCENT-DRTB. She is the chair of the NCRTB Medical Advisory Committee or TB-MAC. Concurrently, she is the medical officer at the V. Luna General Hospital, IDOTS. Doc Guy and Doc Avinash, you may have the virtual floor, please.
Yeah,
Hi,
I am on.
Mana. Good afternoon. Ma'am, can you share our slides? Mamana? Okay, thank you. Can you hear me po, Mamana?
Yes, I can
We
hear
hear
you.
Okay, thank you. Good afternoon, everyone. So welcome to this session on operational and clinical questions surrounding DRTB preventive treatment. Now, as we roll out DR TPT, many practical questions have emerged from the field. To help us answer them, I am pleased to welcome here with me Dr. Avinash Kanchar from WHO headquarters. Dr. Avinash, thank you for joining us. And let us begin with the first question that the implementers frequently ask. Next slide, Mamana. So the first question is testing for TB infection, such as your tuberculosis skin testing, necessary before starting DRTPT? Next slide. So here in this slide, you can see the algorithm that is included in our interim guidelines on DRTPT. The step-by-step approach was already explained by Dr. Mamel in her presentation. Next slide. So from the Philippine implementation perspective, TST, or testing for TB infection, is a major bottleneck in our ASCENT project. Among 285 household contacts that are over 5 years old with no risk factors, TST coverage is only 72%, meaning we already missed 28% of eligible people. More concerning, the TST positivity is only 25%, and that is 15% off from the minimum TST positivity in high burden countries that are in our literatures. As to the constraints of TST, this was already mentioned by Dr. Mamel, and the common reasons for low uptake that includes the 2 visits requirement. So most of their patients, no TST was done due to work schedule conflicts, and there were documentation gap that fails to record positive TST readings. Now, next slide, Mamana. What's also concerning is that the TST positivity dropped to 0% in some of our advanced implementation sites, likely due to cold chain failures or reading errors. Now, in literatures, it has been found that TST positivity among household contacts can be as high as 40 to 60% in high prevalence settings, and here in the Philippines, about 65% in close contacts of TB. As mentioned earlier by Dr. Lono, in their MSF position paper, they saw that positivity fall to as low as 5% because the tuberculin was inactivated. And the operational challenges that we had in our advanced implementation were incorrect storage, reading errors, or documentation gaps, such as some of the facilities have reported the 10 millimeters insuration as negative. So requiring TST can include many who needs prevention. The question is, do we really need, or is infection testing required prior to giving DR TPT? Doc Avinash, may we have your inputs? Next slide, Mamana.
Yeah, I can come in, and thank you for the question. And we hear this question a lot everywhere. So, but there are several things we need to consider. If we think of places like Tondo that we just heard about, where the test positivity rate is more than 90%, I mean, it doesn't make sense to test at all. So we can just start TPT in those cases. But in places where we see like 25%, what it means is if we don't test, we'll be treating 3/4 of the people unnecessarily, probably. So that's a balance that we have to think about. And I agree completely with all the operational challenges with availability of TST, its application, the need to return for reading. So my advice would be for the national program to consider on ways to tackle these issues separately. Because what we know is if a person is TST positive and you give TPT, he's likely to benefit. But if he's TST negative and we still give, there are some risks that I mentioned, particularly in adults, where they are not life-threatening, but still they would lead to discontinuation of TPT in any ways. So I think we'll have to think of this balance, and the way we suggest countries is consider the antigen-based skin test, for example. It says they are better tests and they work on similar principles as IGRA, so they are likely to perform better than the TSTs, which may not be quality controlled nowadays, or the supplies may be an issue. So consider antigen-based skin test. And consider using technology for transmission of results, for example, to make it more easy for people to get the results in time. But overall, what I suggest is for populations that we have clearly highlighted: children under 5, people with HIV, people with risks that Dr. Mamel mentioned. These are the ones that we don't need to test. Others we should test if the resources allow. But in the end, if we are not able to test because of lack of resources or lack of availability of the test, we should still consider TPT, because TPT is the priority here. Even if the test is not available, you can treat. But in an ideal world, you would want to treat only after testing. So we'll have to strike a balance. The national program cannot issue a blanket given very low TST positive rates. And this is not only Philippines, we have seen this in Vietnam and other countries as well, where the positivity in general is quite low. And the reason could be the TST itself. It may be application of the test. There are so many other reasons, but we cannot have a blanket as a guideline, but we can have some specificities included in the guidance. We could have populations that don't need test, situations where we may not test and still give TPT. I hope this clears and not adds to the confusion. Over.
Thank you for that, Dr. Avinash. Ma'am Anna, next slide. So for our next question is on effectiveness. How effective is the 6-month levofloxacin as a preventive treatment for MDR-RRTB, and what evidence supports it? Ma'am Anna, next slide. So our Philippine interim guidelines adopted the 6-levofloxacin in September 2025, but most of our patients are still under treatment. But we are already eager to see the real-world effectiveness that would probably match the trials. So what does the evidence say? Dr. Avinash? Next slide, Ma'am Anna.
Yeah, so what was noted in the TB Champ and Weekwin was even during the follow-up period, which was more than a year, the protection still continued. So what in general for TPT, WHO doesn't really advise for a repeat course of TPT at certain frequency. Like some countries do it every 3 years, but as WHO we don't really advise that, because there is no evidence from any for any of these TPT regimen increasing risk of drug resistance or so we don't have any evidence, and that's why we don't ask for repeat course of TPT in general. But if a new exposure is confirmed and the clinician feels that the risk is there for a certain individual, we can consider a repeat course. But it should not be at a programmatic level. It should be at an individual level.
Next slide, Ma'am Anna. Next question, Ma'am Anna. Okay, so we have already discussed about effectiveness. Now the next question is on safety. How safe is 6-levofloxacin to be given as a preventive treatment for DR TPT? Next slide. So in our ASCENT implementation sites, we visited most of our advanced implementation sites. There were no reported any adverse events among household contacts that were started on the 6-levofloxacin. So it appears to be relatively safe, but what does the global data show, Dr. Avinash?
No, I think it's clearly in line with what we saw in the TB Champ and Weekwin studies. In children, levo is very well tolerated in general. In adults also, it is tolerated well. Some like one fourth of the individuals would develop some adverse events, but most of them can be managed easily at the clinical level. So people don't need to be admitted. People don't need to be stopped. So in general, levofloxacin is quite safe, and it can be used safely.
Okay, thank you. Our next question, Ma'am Anna. So from effectiveness, we talk about safety of our 6-levofloxacin. Now let's proceed to the test that we need in order to start DR TPT. Our procedures such as our liver function test, ECG, now are they recommended prior to giving 6-levofloxacin? Next slide, Mamana. So our interim guidelines do not require routine ECG and LFTs prior to starting 6-levofloxacin. However, we do request ECG for patients who are more than 60 years of age, those who have cardiac history, those with concomitant use of QT prolonging drugs. For LFTs, we usually request this for patients who have suspected liver disease. So in our interim guidelines, we take a targeted approach. So does WHO agree with this part of our guidelines, Dr. Avinash?
Yeah, completely. I mean, this is in line with the WHO guidance. We don't need routine baseline LFTs or ECG, and it has to be targeted. And that's why the baseline evaluation is critical. We need to look for a history of any of these risk factors that were mentioned in the previous slide and then test accordingly. But we don't need for everyone.
Thank you. Now, this next question, this is also a common question that we have encountered in the field. Now, if a patient finishes already 6-levofloxacin as preventive treatment and later on was found to develop active DRTB, will levofloxacin still work? Will scaling up 6-levofloxacin not lead to increased resistance? No? This is a next slide, Mamana. So this is a common fear among our sites that we have visited. But just like isoniazid preventive therapy for drug-susceptible TB, completing 6-levofloxacin does not disqualify a patient from being given BPAL-M or BPAL. They are still considered a new TB case. So if 6-levofloxacin fails to prevent TB, have we ruined future treatment option by giving fluoroquinolone in the regimen? Avinash?
Yeah, as I said, there is no real evidence for any of the TPT regimens, including levofloxacin, of increase in drug resistance risk because of TPT scale up. And the logical reason is we start TPT only after ruling out active TB, and if we can do that for every patient, so it's unlikely that the drug resistance would emerge within the same person. And people are more likely to acquire infection from the community, which is more often drug sensitive. And levofloxacin as well, we know it doesn't increase cross resistance with any other drug. So it's in that sense it's unlikely to add to the drug resistance risk, and it will still work if there's a need to repeat the course of levofloxacin. Over.
Thank you, Dr. Avinash. Next slide, Mamana. So for our next question, this is also not uncommon in our ASCENT project. What DRTB regimen should we give to a household contact who was exposed to 2 index cases with different resistance profiles? So one DSTB, drug-susceptible TB, and one with rifampicin-resistant TB. Next slide, Mamana. So this is not uncommon in our ASCENT project. We often see households with more than one index case. The complication is when one is drug susceptible and the another index is rifampicin resistant. So what we usually advise is we assess the intensity of the exposure. For example, sharing a bedroom with one index case versus another. So the higher risk exposure should guide the regimen. Your thoughts on this, Dr. Avinash?
Yeah, in this case, what I would suggest is if we go by the higher, the worse exposure probably, and not get into this assessment of risk of exposure, because this may not be done well in the field. So best is to go by and give levofloxacin instead of 3HP in such cases probably.
Next question, Mamana. So another question we encountered in one of our advanced implementation sites is, should a patient who has finished 6-levofloxacin repeat another course if he is again exposed to another MDR or RTB patient? If yes, after what interval? Okay, so for this is actually a policy gap for many of our programs, and here, we usually repeat course should be considered for those who completed TPT but are subsequently pre-exposed. So this is like a case-by-case decision. So Dr. Vilash, do we retreat? Do you suggest retreat?
Yeah, agree. I mean, it has to be case by case. It cannot be for everyone. And it's a decision of the clinician. If he notices that there is a new exposure with a drug-resistant TB patient, he can consider another course of levofloxacin.
Thank you. Now we're down to our last question. What do you tell a patient who says, I feel fine, why should I take this preventive treatment? Next slide. So this is perhaps the most common question that at bedside. In the Philippines, patients often say, wala akong sakit or I'm not sick, which is actually a common and valid feeling. So how do we respond, Dr. Avinash? We usually explain that the medicine cuts the risk of getting hard to treat TB disease by 60%, that TB infection is silent and without prevention, it could become active, requiring longer, stronger treatment. We also explain that side effects are usually mild and manageable, but the benefits of preventing DRTB far outweigh the risk. So what would be your key messages to these patients who usually say, why will I take this preventive treatment if I don't feel anything?
Yeah, I think the fourth point here is really a strong argument in the counseling, and usually the contacts have seen for themselves. They have a family member who is suffering, who needs to take a lot of medication. There would be side effects of MDR-TB treatment, so they have a first-hand experience of this, and so yeah, I think the health workers need to point this out and explain that this can all be avoided by taking one sort of treatment for 6 months, and that which is safe, which is freely available. So I think this is the challenge we face for all TPT in general, because the individual is fit and fine, and he's there needs to be some talking to be done, and because they have a family member suffering, it's easier. But the most critical element here is the timing. I mean, if you can do this as soon as possible after the diagnosis of the index patient, it's easier to convince the individuals, and that's why we have this. If you go to the operational handbook, we have this 717 framework that we suggest, where you try and reach the person, the contacts, within 7 days of the diagnosis of the index case, get the evaluation done in a day, and then start the TPT within another 7 days. So if you can do this early, it will help. Over.
Thank you. Thank you so much, Dr. Avinash, for answering all of our frequently asked questions. This has been immensely clarifying, from operational challenges with DST to the strong evidence of 6-levofloxacin. You explained about the safetiness, the monitoring, the patient communication. You have actually given us like a practical roadmap in how do we implement our DRTPT. So on behalf of KNCV Philippines and all the implementers here today, thank you so much, Doc Avinash, for your time and your evidence-based guidance, and your commitment to ending TB. Thank you so much.
Thank you very much. Thank you very much.
Back to you, Mamana.
Thank you, Dr. Avinash and Dr. Guy. So we have now come to a close for the first part of our webinar. For the questions posted in the chat box, we will answer it individually for issues of time. So again, we'd like to thank all the speakers on the RTPT for the very informative session. We hope that indeed our mindset toward the RTB prevention has changed after we have understood the importance of the RTPT, the effectiveness and safety of 6 months levofloxacin as preventive treatment for contacts of MDR or RTB. And we also would like to thank our online participants who have stayed online up to this time. At this point, we will pause for a 5-minute break before we proceed to part 2 of our session. So please be back at 5:55. So you can have your break. So are we ready for the second part of our webinar? So this time, we will shift from the prevention to diagnostics. This session will be about non-sputum testing using stool for LC-NAAT. And to discuss the first topic on the WHO evidence and guidelines on the use of stool for LC-NAAT, I'd like to call on Petra Dehas. Petra Dehas is a senior laboratory specialist in KNCV and is no less than the inventor of the simple one-step or SOS technique for stool-based diagnostic testing for children. She provides technical assistance to laboratory networks within countries. Petra, you may have the virtual floor, please.
Thanks, thanks a lot, Anna. Yeah, thanks. And I will present on the WHO guidance around stool testing and also around the SOS stool method. So let me try and share my screen. And see if that works on the presentation. Like this. So can you see my screen?
Yes.
Yes, we can see it.
Perfect. So yeah, so as I said, I will present on the WHO evidence and guidelines based on the stool-based testing to diagnose TB. And I want to first take you to the latest data that is presented in the latest report on 2025 from WHO. And here you can see that in 2024, wait, I have to go down like this. 1.2 million children and adolescents develop TB, which is around 11% of the total burden, and of which 47% are under 5 years old. So that's an important thing to recognize. 175,000 children and young adolescents died, which is about 16% of the total deaths that are caused by TB. And these figures, they are quite serious and have not changed much in the past few years. So that means there's seriously action needed. And I think there's also a lot of action taken by WHO for this. So to go to the treatment coverage rate, so you can see also here that the treatment coverage rate, especially under the young age group, is there's a high number of missing cases. It's even above 50% for the ones that are under 5 years old, and which is mainly due to the underdiagnosis and underreporting. Reasons also for treatment coverage gaps are also that the children generally have a very possible ciliary TB. And they also, it's very hard to collect the sputum from the respiratory sample from the children. You can imagine that the children under 5 years old, they cannot produce a sputum on command. And so you really need to use invasive methods to collect the sputum in general. And the other thing is also that there's an overlap of symptoms with other common childhood TB diseases, and there's a limited capacity to diagnose children with TB. So also on the capacity part of staffing and also the confidence in the clinical diagnosis, there's still things that can be improved. Just to bring you to the stool, why stool? So stool is a proxy for a respiratory sample. So as I said, the collection of a respiratory sample from children is challenging, and it requires very invasive methods like gastric aspiration or sputum induction. And these can also often not be done at the healthcare centers, the lower healthcare levels. You really need hospitalization and also you need specific equipment to do this test, to take these samples. And children naturally swallow their sputum, so excreting embedded pulmonary tuberculosis directly within their stool. And since 2020, we were able to get WHO recommending the stool as an initial test to diagnose TB in children less than 10 years. And that was really quite a change for the TB diagnosis in children. So since then, there was a lot of guidance that has been developed. One of them is the Operation Handbook on Tuberculosis, the Model 3, I think well known. In 2020 already, it recommended the stool on expert MTB-RIF. And in 2021, it was also recommended on the ultra test because then also more data was available. But already there are more updates available on this handbook, even one from 2025. And I will come back to that. Finally, we also had Operation Handbook on Tuberculosis of the Management of Tuberculosis in Children and Adolescents, which I think was a very important handbook that came available, and stool testing was also a part of that. And the clinical algorithms were very well described, but also the stool processing methods that were officially recommended by that time. And out of that, we also created a stool handbook, a practical manual of processing stool, which has practical considerations, but also indicators. So it's a lot of practical things that you can take from that handbook. So as I said before, so stool since 2020 has been recommended as an initial test to diagnose TB in children less than 10 years old, and that was also like as a single test. It was recommended since then. But since 2025, we have received new guidance from WHO. And in those guidance, it was mentioned that a stool should be tested concurrent with a respiratory sample. And the concurrent testing was prioritized over the use of a single molecular test, but they also clearly stipulated that evidence supports also the use of a single expert ultra on sputum, gastric aspirate, stool, and NPA as an initial diagnostic test. And that was really important because we were a little bit afraid that we would be pushed back, because by bringing stool as a sample type to diagnose TB in children, we also created a lot of access, as we just said, as it is very difficult to get a respiratory sample from the small children. But it was also very well noticed by the WHO, and WHO also said that ultimate decision for implementation of concurrent testing is depending on the feasibility, acceptability, budget, but also on the operational research, because there's still some more information needed. But the reason why they made that push to do like 2 tests instead of 1 test is that they saw a very high incremental yield if 2 tests were done, especially for children, the young children, because of the possible bacillary TB. And from the data that they are presenting in the WHO guideline is that they saw that there was a 7% incremental yield if after a respiratory sample, a stool sample was tested, and also on the other side, if the stool was firstly tested and then secondly a respiratory sample was taken, and the incremental yield came to 22%. And that is for these vulnerable groups of patients. I think it's an important incremental yield that we should not ignore. But then another point is very important to also recognize that when you look at the review data at the WHO consolidated guideline, you will see that the sensitivity of a respiratory sample alone, respiratory is meant not only sputum, it's everything that has been taken as sputum. So it could also be the GA, the NPA, anything that is combined, that's a respiratory sample. And that is still the highest sensitivity, and we should just recognize that. So if you go to stool alone, it will be 68%. So it's a little bit less, and then gastric aspirate alone is 69%, and NPA, the nasal pharyngeal aspirate, is only 46%. And you can also see clearly here the specificity. Oh wait, I have to go. It is not. Oh yeah, sorry, I pushed the wrong button. Here you can also see the specificity, and the specificity of the stool alone came to 98%, and the gastric aspirate alone on 91%. And this is data that has been done by the systematic review that is always done by WHO when they do the guideline development. And you can also see the number of studies that were involved and the number of participants in these studies. So this is an important information because it very clearly shows that the stool alone and the gastric aspirate alone have like similar sensitivity. And knowing that for children, it is difficult to get the gastric aspirate, you could also think of doing 2 times a stool. That's the thing that that is the step that I would like to go to, is that from a KNCV study where we tested a 2 times stool, we noticed that if you have a first stool and a second stool, for adults, you will have a 9 to 10% incremental yield. And if you take children under 10 years, it's already 12 to 15%. And if you look into the pulsar TB of that group that we investigated, we already saw an incremental yield of 15 to 17%. So you can clearly see that the 2 times stool can also be helping to increment the yield. And that has been under discussion with WHO. And of course, this needs further investigation. But what we can say for now is that stool is a rule-in test as part of a comprehensive package. It's never a standalone test because you always want to do more to ensure you don't missing the TB. But for young children, the incremental yield of testing a respiratory and stool might provide a similar incremental yield compared to testing 2 times stool. And this needs further investigation. And it's important that countries start testing children that have an MTB negative result again. And I want to show you the KNCV simple one-step stool method. As we said, we as KNCV, we invented the simple one-step stool method. It's one of the 2 methods that is recommended by the WHO in 2020. There's another method that is recommended, which is based on a sucrose layer, which is a more complex method. And we have shown that there are similar sensitivity and specificity compared to the complex method. So that was really a good achievement. So that means that the simple one-step stool method can be used as such. And you can see that there's no additional supplies required than for sputum expert testing. It is only that the steps are a little bit different. And what you can see here in those pictures is that you just take a little bit of the stool, a little spoon that is normally provided with the stool cup, and you bring that into this little bottle, and then you're going to shake it. And I'm sure that maybe Lisa, you will explain a bit more on this as well. You shake it, and the shaking is an important step because you want to ensure that the bacteria gets free from the debris. And then you have to let it sediment, and the sedimentation, the debris will go down. You just take the upper layer in which the bacteria supposed to be, because they like to go into the liquid, and they will float up to the top, and then you bring that into the cartridge, and then the cartridge can be tested. So it's easy to implement at low cost, and as I said, you don't need any additional supplies compared to the sputum expert testing, and the method has been shown to be robust and relatively low in the error of invalid rates. And you can also see all this, the papers that have been published, and there's a longer list, of course, but these are really important papers. And I also want to emphasize that since 2026, I have to say, because that's when we were able to publish this, is that we have also been able to test the SOS stool method using the expert MTB XDR test and also on the TrueNat MTB assay. Of course, this is not yet recommended officially by WHO, but we are working on creating enough evidence so that this can be recommended by WHO. Just to give a kind of update on the uptake of the stool-based testing. So this is the map of the world, but we don't have all the information. This is the information that we have been gathered together by speaking with the countries and also working with countries. And you can see that quite a high number of countries have already implemented the stool. And you can also see on the color which stage of of implementing they are. Like the routine introduction is green, where the implementation of pilot sites is yellow. And I think also for the Philippines, I think the color can change already. So finally, we had a workshop at the Union Conference 2023 in Paris, where we have had a lot of countries presenting on the stool-based testing implementation, and it was quite interesting to see how many countries were already working on it. Many of these studies have been published, and so you can look for them. And you also see quite a diverse amount of positive MTB yield, and that's also depending on, of course, the selection of countries, but also the incidence in the countries among children. But we saw that Nigeria, who has done a huge number, that also took the lead in that way. And we found among the 60,000 that were tested at that time, already 5% of them were tested positive. So that's quite an achievement. And you can also see the publication that is below that shows practical lessons learned from those early pioneers. We had another workshop, which was really fantastic to have the workshop at the Union in 2024 in Bali, and where we have been focusing on the Asian countries. And we were very pleased that Philippines already presented their first plans on implementing the stool test, but also Indonesia, Vietnam, and Bangladesh have been presenting at that union. And I think from all the work that we have done so far in the past years, I can safely say that stool-based testing has shown to increase access to diagnosis of TB in children and others, because it also benefits adults in many countries. So I would like to say you cannot eliminate it if you do not detect. So we have to be sure that we do that. And thanks a lot.
Thank you, Petra, for sharing that stool is another specimen to be used for TB diagnosis for children. So moving on, we have heard that sputum is not the only specimen that can be used to detect TB. So again, from global guidelines, let us hear about the guidelines development in the Philippines. So that's from sputum to non-sputum testing. So let's hear from Ms. Brasike Mabansag. Ms. Brasike Mabansag is a registered medical technologist with Masters of Public Health degree, and she is currently serving as a science research specialist at the National TB Reference Laboratory. Contributing her expertise to advance TB diagnostic and public health.
Hello, good afternoon, good evening, and good morning. Is my audio clear po?
Yes, Miss Brasike, you are clear.
I'm sharing my slide now. Is my slide showing on the screen?
Yes.
Okay, thank you. Uh, Good day, everyone. So I'm Kay Mabansag. In behalf of Dr. Ramon Basilio, the NTRL head, I will be presenting the guidelines development from sputum to non-sputum test. For the context of the burden of TB, according to the 2025 Global TB Report, in 2024, over 1.2 million died from TB, with approximately 11 million new TB cases reported worldwide, including our country. In the Philippines, the burden of TB shown in this 10-year period. This highlights that how TB was worsened in the Philippines over the past decade, and the three upward arrows emphasize the increased ranking in incidence and case notification, showing that despite the improved reporting, the overall TB burden has grown significantly between 2014 and 2024. This shows that TB remains a serious and underreported health issue for children in the Philippines. And despite a decade of progress in TB control, childhood TB continues to be significantly underdiagnosed and underreported. So only 1 in every 2 children with TB are notified, and only 51% incident TB cases among children worldwide are either diagnosed or underreported. Even if we are using the WHO recommended LCNAAT, TB in children is still underreported because of the challenges of collecting specimens and possibacillary TB, which causes low bacterial load and making it more difficult in confirming diagnosis and drug resistance. To address these challenges, there were several evaluation of tests using different specimen which can be easily collected in children. One of these is the stool. Stool is recommended as an alternative specimen for diagnosis of TB in young children as they cannot easily produce sputum. One of this method is the simple one-step SOS developed by KNCV, which is a simple stool processing method for the detection of Mycobacterium tuberculosis or MTB using GeneXpert MTB Reef Ultra. The availability of this method was recommended by the WHO starting in 2021. This prompted WHO to update the guideline of rapid diagnostic for tuberculosis detection. The guideline endorses 3 classes of NAATs, including the low complexity NAAT for rapid TB detection. This emphasizes on the standardized protocols for stool collection, processing, and testing. From 2022, at the central level, there were a series of consultation meetings with DOH, NTRL, USAID, and KNCV. KNCV is Tuberculosis Foundation is an international nonprofit organization dedicated to fight against TB and other health-related challenges. During the activity, it was discussed on how to adopt the new WHO guideline programmatically at the Philippine settings on the application of LCNAAT specifically for the children. By 2023, after the consultation meetings, the program decided that a technical expert in the country should be trained for the rollout of SOS. Ms. Coprada was the selected country representative and underwent SOS training organized by Uganda SRL. And by 2024, after the SOS training to the country representative, a pilot training for the SOS were provided to the 2 hospitals, the National Children's Hospital and Philippine Children's Medical Center. These facilities were selected because of the high TB case for children. During the start of 2025, TB Luzon developed the concept note for SOS implementation, and also during this quarter, NTRL Learning and Development Section introduced the SOS self-paced Canvas platform for the trainers and regional coordinators. These regional representatives will cascade the SOS training to their respective regions. And by the second quarter of 2025, NTRL LNSS drafted the interim guideline. Sorry. And by the third quarter of 2025, consequently, there were consultation meetings with stakeholders composed of selected regions, pediatric societies, patient groups, and public and private children's hospital to discuss further the development of the SOS guidelines. Also, a supplemental training of super users through the NTRL LDS were conducted for all these regions these super users are the technical experts or resource person to their corresponding regions regarding SOS. There were one SOS super user trained per region. So by the end of 2025, the department circular was signed and disseminated to endorse the interim guide of stool-based LCNAAT for PTB diagnosis among children. So attached to this department circular is the interim guide developed by NTRL's Laboratory Network Strengthening Section, fulfilling the mandate of NTRL in providing technical assistance to the Department of Health. So here is the outline of the guide with technical guidelines and 6 operational guidelines. So if you are interested to know the specifics of this interim guide, you can scan this QR code to download the document. And by January 2026, facilities nationwide started to request and utilize SOS. Also, starting on the 3rd week of January, the series of monitoring activities were conducted to selected facilities in regions NCR 5, 9, and 7. These monitoring activities aim to evaluate the adherence to the guidelines of stool-based LCNAAT for PTB diagnosed among children. And after 6 months of implementation, the program, there is a scheduled program implementation, which is aimed to evaluate the 6-month implementation of the stool-based LCNAAT for children. And we just want to acknowledge our valued collaborators in the implementation of stool-based LCNAAT for PTB diagnosis among children. So these are our valued collaborators. And thank you so much for your attentive listening.
Thank you, Ms. Brasike, for sharing with us that story of how the stool-based guidelines is made or crafted in the Philippines. So moving on. So from the guidelines development, we now move on to the implementation considerations of the stool-based LCNAAT for pediatric TB. And to tell us more about it is Ms. Larissa Coprada, who is the KNCV Laboratory Consultant for KNCV Philippines. Ma'am Riza, the virtual floor is yours.
Thank you very much. Thank you very much, Ma'am Ana, for the introduction. So good day, everyone, and thank you for the opportunity to present. So today I will be sharing the Philippine experience on programmatic implementation of stool-based LCNAAT in the Philippines. In this presentation, stool-based LCNAAT refers to expert MTB-RIF Ultra using stool samples. So next slide, please, Ma'am Ana. In the Philippines, about 27% of the population are children under 15 years old. This represents a significant proportion of individuals who may face challenges in accessing TB diagnosis in the country. At the same time, childhood TB remains underdiagnosed and underreported, highlighting a major gap in our health system. As you can see in our graph, for the past 7 years, we did not reach the global target and the national target of 12%. So the mindset shift, for many years, sputum has been the standard for TB diagnosis, including young children and adolescents. But many children simply cannot produce sputum which limits their access to bacteriological confirmatory testing. Because of this, we need to shift toward more inclusive approaches. Instead of relying only on sputum and gastric aspirate, we can use stool as an alternative specimen. This challenges the traditional thinking of no sputum, no bacteriological confirmation, and opens the door to more child-friendly TB diagnostics through stool-based expert ultra testing. Next slide, Ma'am Ana. Next slide, please, Ma'am Ana. Okay, thank you. As mentioned by Petra and Ma'am Kay, there are several reasons why diagnosing TB in children is difficult. So children cannot often produce sputum, making sample collection challenging. Fewer bacteria is seen, making detection harder. And most of all, we always rely on clinical diagnosis. And the result, we have missed or delayed diagnosis. So to address this gap, the stool-based LC-NAAT or the stool-based expert ultra testing was introduced, a non-invasive, child-friendly diagnostic approach that detects TB DNA from stool samples. The SOS was developed by KNCV, and because of its simplicity in processing, it is widely used globally. So why stool? Usually, as mentioned by Petrano, children while sputum passes through the gastrointestinal tract and it was excreted through stool, meaning TB bacteria can be detected in stool. So instead of struggling to obtain sputum, we use a sample that is readily available and easier to collect. Am I right? So next slide po, Ma'am Ana. So just to provide you an overview of the implementation status in the country. So stool-based expert ultra testing is now a nationwide routine implementation already, no? So once the region or once the lab analysts were trained and partner referring facilities were oriented, they can now start referring and processing stool specimen in their respective regions. So in this implementation those early implementers serves as the sentinel sites, no? So we have, as mentioned by Ma'am Kay, so we have 4 regions that serves as the early implementers that includes the Metro Manila, 5 region, Bicol region, Zamboanga Peninsula, and the Central Visayas. And we are targeting the children and young adolescents 0 to 14 years old. And also, most of the early implementers are those coming from the hospitals, health centers, and rapid TB diagnostic laboratories or the city health office laboratories. Currently, we have now 1,018 TDL that if this will be trained, we have easily access to the processing of stool-based LC-NAAT. Next, Ma'am Ana. So for the policy context, the shifting of sputum-based to stool-based in the country is backed up by the policy, the DOH Department Circular, with the Circular 2025-0517, which is the interim guide on stool-based LC-NAAT for diagnosis of TB among children. This provides guidance to the implementers. This guidance was aligned with the WHO recommendations, and we ensure that the stool-based LC-NAAT is integrated to the national TB algorithm. Next slide po. So following the issuance and dissemination of interim guidelines, capacity building for laboratory personnel was conducted. Since most laboratory analysts were already trained in expert ultra, a supplemental training on simple one-step stool method was provided. This training initially targeted expert trainers who then cascaded the training to the respective regions. So beyond the laboratory personnel, or the laboratory analyst, it is equally important to orient the healthcare workers on stool-based LC-NAAT. This ensures that they understand the patient eligibility, proper stool collection, storage and transport, and referral mechanisms. In addition, not only the healthcare workers, but also the striders were also oriented to ensure that the proper handling and transport of stool specimens that they are transporting maintains the integrity throughout the process. Next slide, please, Ma'am Anna. So as mentioned by Ma'am Kay, we also conducted a monitoring and supportive supervision. We conducted a joint monitoring and supportive supervision together with the Department of Health, the National TB Control Program, RITM, National TB Reference Laboratory, KNCV, and our regional Center for Health Development's coordinators. This allowed us to look how stool-based LC-NAAT is being implemented both at the facility and laboratory levels. We also assess how well sites are adhering to the interim guidelines, including the simple one-step stool method. At the same time, we identified key facilitators, ongoing challenges, and immediate support needs on the ground. And most importantly, these visits help us generate actionable recommendations to further strengthen the program moving forward. Next slide, please, Ma'am Anna. As the early results shows, among 18 regions, 39% started the implementation already, meaning they already process specimen, stool specimen, while others are in the training stage. We're in 56% of the regions started their training, and for the number of stool tested, this is as a disclaimer, this is not yet the final data. This data came from only from 8 laboratories. So we have 195 stool examined, and 6 were positive with the positivity rate of 3%. And also we experienced for the initial result 4 invalid results that includes 1 error, which is error 2008. Next slide, Ma'am Anna. So for the key gaps and challenges, so we have gaps in orientation. So we see many laboratories are trained already. The expert laboratories are trained. Expert operators or the laboratory analysts were trained already, but there were no referrals coming from the referring facility. So there is an orientation gaps. What we did in this orientation is that we had, during visits, we did a crash course on the orientation on the stool-based LC-NAAT. Then we have we have limited EC materials for awareness. And then for the service delivery, we have poor adherence to diagnostic algorithm because we have a problem on the logistics, which is the inadequate supply of cartridges. So in our algorithm, we have to repeat the test of all negative results of the children, but we are not completely doing it because we have lack of the supply of the cartridges. We have also delays in referrals and specimen collection. For the repeat collection, that is also one of the problem, especially those patients coming from the referral coming from the hospitals. So after the test was done, so repeat collection is needed, but we cannot find the patient anymore because the patient were already discharged. So for the logistics and supply, so although we don't need the weighing scale because NTRL already taught the trainers on how to on not using on how to assume or the sample, the sputum sample, but our medical technologies on the ground or our laboratory analysts on the ground wants to have a weighing scale first until they are used to that to that amount of the stool to be processed. So clearly, we have still we have this gap and challenges, but still have areas to improve. Next slide po, Ma'am Ana. So for the early lessons learned, so early adoption, first, we have early adoption and timely dissemination were key in getting information quickly and promote the stool initiative and increase referral uptake. So integrating stool-based in facility workflows made the implementation seamless. And if we are documenting the feedback and tracking specimens, quality issues improve, test accuracy, and refine our approach in the implementation. The simple coordination tools, such as group chats, prove highly effective in improving communication and boosting referrals and testing. Next slide, Mamana. Next is that if we have strong advocacy and stakeholder engagement, it can sustain the momentum and ensure that our program on this stool-based initiative will be a success. And next po, we also emphasize that continuous learning and support systems to keep teams informed and confident on what they are doing. So that's why we have a monthly learning sharing of experiences so that everyone can learn on the experiences of others. And then lastly, ensuring that readiness supply prior to start of implementation so that there will be no interruption on testing. So next slide po. So as a recommendation, so continue awareness campaigns. So we have to continue the awareness campaigns to enforce the diagnostic shift to non-sputum specimen among clinicians and communities. And also we have to sustain the regular stakeholder meetings to review progress, share lessons, and strengthen to strengthen the accountability. So next slide. So as a next step, so we will be having an assessment of the stool-based LCNAT Expert Ultra initiative by having the acceptability survey among healthcare workers, among the lab analysts or the expert operators, and also for the caregivers. And also we will be having program implementation review. And then after the assessment, we will be having the finalization of the interim guide on the stool-based LCNAT. So to close, stool-based LCNAT is more than just a new diagnostic option, but it represents a shift toward a more inclusive and child-centered approach to diagnosis. So our early experience in the Philippines shows that while challenges exist, they can be addressed through strong systems, continuous learning, and collaboration. And most importantly, this approach allows us to reach children who might otherwise be missed. Thank you very much. So I would like to acknowledge the Philippines Department of Health, the Disease Prevention and Control Bureau, the 18 Centers for Health Development, the RITM, National TB Reference Lab, USAID, IDDS, PBSP Access TB Project, FHI 360, KNCV, the Netherlands, and KNCV, the Netherlands. Thank you very much po.
Thank you, Ma'am Riza. So, thank you for walking us through the implementation considerations in the Philippines for the stool-based LCNAT. So you've shared the key gaps and challenges as well as recommendations and lessons learned. So for both part 1 and part 2, there's a strong word for collaboration. I've been hearing it for several times. So collaboration is a strong word for this webinar. So moving on to present to us the few FAQs for the stool-based LCNAT. Ma'am Riza, Would you like to share your slide?
Okay po, thank you, Ma'am Ana. I would like to confirm po if you are seeing my slide. Meron po for my slide.
Yes.
Yes, ma'am.
Thank you po. So to complement the implementation, we have compiled a set of frequently asked questions based on common inquiries gathered during training orientations and monitoring visits. These FAQs are intended to clarify key aspects of the program, particularly on the implementation process. By walking through these questions, we aim to ensure a shared understanding, minimize confusion, and support more consistent and effective implementation. So together with me in this presentation, who will respond to the FAQs is the scientist behind the simple one-step method. And I'm very grateful to have her because she's one of the trainers in the Uganda supranational laboratory when I was there. And she just recently appointed in South Africa WHO technical advisory group on HIV, TB, hepatitis, and STI. So I would like to call with me Petra De Haas. Petra,
Yes,
can you share a word? Thank you.
yes.
Okay, let's start because it's already past 6 o'clock. No? So for the question number 1, so why do tarry or black stool specimens sometimes produce invalid results initially? And when you do repeat testing, it often yield negative results. Petra, this?
Yeah, I think you can click the next one because then you see the answer.
Okay.
Yeah, so the answer is that the terry stool, that's a dark stool. Sometimes that normally it's because there's also blood in there, because the dark stool also means there's blood somewhere coming into your stool, and those are specific inhibitors, so that will interfere with your test, and that's causing invalid results. And also due to the dark color, and you can see the bottles that are there in the picture, it's very difficult to see the sedimentation. Like the first bottle, you can see that there's a sedimentation, even it's already dark, the supernatant is a little bit dark. But in the other one, you can hardly don't see the sedimentation, and that also makes it very hard to aspirate the supernatant carefully, and avoiding to take the debris. And so the recommendation would be that you repeat it from the same stool using less stool, because we have already noticed that even with a lower amount of stool, your test will still be positive if the bacteria are there. And you also should be more careful with the aspiration of the supernatant. And if invalid again, of course, you then try to get a fresh sample to test it again. And also you can also look at the sample positive control, which is always in the test, and you can see how this has behaved. I'm not going too much into the technical details, but if it's getting above a certain amount of cycles, as we call it, so the more you need to copy it, then also it is an indicator that there is an inhibitor there, and you should be careful interpreting the result. So these are the kind of takeaways for when you have a tarry or black specimen.
Thank you, Petra, for that response. So for our next question is that after an invalid result using a stool specimen, what is the acceptable time window for repeat testing using the same treated sample? This is usually asked during the training of the lab analyst.
Yeah. Yeah, so as soon as you bring the stool together with the sample reagent, and maybe you can already bring the answer up as well, so people can read with me. Is that then? So when you go to the next, yes, then also of course, then already the buffer is interfering with your stool. And we know also from sputum that can cause some test performance can be affected by that. So you should not keep it too long together. That's what is always advised also by the manufacturer. So when you want to do a repeat testing using the same sample, you should do this within 4 hours. And beyond this period, test performance may be affected. Ideally, a new portion of stool should be processed, because also when you want to take another 2 ml from that supernatant, you can imagine that if you already took 2 ml from the supernatant, then you are getting closer to your debris, and it also gives you a risk that you are transferring some of the debris. So always it's better to process a new specimen, but if not possible, you don't have another stool left, then of course you could try it, but take all these cautions into consideration.
Okay, thank you very much, Petra, because this question it's not in our SOP. We will be surely incorporate this in our SOP finalization of the guidelines. Thank you. So for the question number 3, thank you. Why is a second test needed if the first result is MTP not detected? Because in our usual, if we are sputum negative patients for children, we are not doing the second test. So why is it that the second test now is needed, even if it is MTB not detected?
Yeah, and as I explained in my my presentation, is that at the moment also the WHO is recommending to do a second test, to do a concurrent test between the respiratory sample and the stool, but that's of course not always feasible. But the second test is recommended also because a single test does not rule out the TB. We know with children that they have very post-bacillary TB, and then if you only do one test, then it might be a risk that you might miss it, because the number of bacteria in that specific sample that you took is just below the detection level. So by repeating and taking another test has shown to improve the incremental yield, as I already showed you also in the slides. That's even up to 22%. And so in line with the recommendation from WHO, repeat testing is advised after initial MTB negative result. And this can be either from the same stool or from a respiratory sampling, depending on the sample type that you have available. So that's a very good point. And I'm happy that Philippines is also looking into this to get more data available for this.
Yes, we are having this data. We have the 2-step testing database with this, but however, we cannot do that with the lack of cartridges as one of our challenges. But I hope that this will be done. Thank you.
Yes.
For the question number 4, can we process stool with mucus or blood?
Yes, maybe you need to say next slide.
Yes.
If there's blood, as I said also in that first one, when it's a bit dark, the stool, if there's blood, then the test is always a little bit, the performance of the test is interfered by blood, because it's a PCR test, and it's always when there's blood, that's a problem. Also for sputum, if there's blood in the sputum, we know that we can just try to test it with the NAT test, but still we need to be careful with that. And so finally, what you need to do is to try to avoid the parts of the stool that have the blood visible, if you can do so, and otherwise you just need to give it a try, but keep very clear cautions when you interpret the result. And if you have a mucus rich portion, of course it's good to take it from that side, because it might also contain higher bacterial load, but it's absolutely possible to test them.
Okay, thank you for that, Petra. For the last question, this is the last question. Can stool that has a very hard consistency be tested as it does not emerge easily in the buffer?
Yeah, that's a question that we have received a lot also from doing trainings and everything. It's clear that if you have such a hard stool, it's really difficult to break it down, and so you really need to use applicator sticks to break it, and that's also in the SOP. And if not, it will be good to also add that to your SOP, because it's important to ensure that the whole stool is immersed in the buffer. Also to ensure that the bacteria are, disinfected, because they need to get in touch with the buffer, but also to ensure that the bacteria are released from the stool. So you really need to force a kind of effort by using the applicator to break it down. And so shaking for 30 seconds, as I always tell them, is really important, whatever kind of consistency you have, because with the shaking step, you really are able to force the bacteria to come free from the matrix. And that's a very important step. And thanks a lot for all these questions.
So that's it for the frequently asked questions for the stool-based expert ultra testing. And I would like to personally thank Petra for taking time to respond to this question. Your input was incredibly helpful and has added clarity and value to the information that we are providing to our healthcare workers. Thank you very much, Petra.
You're very much welcome. Thanks so much.
Ma'am Ana, back to you po.
Yes, thank you very much, Petra, and thank you very much, Ma'am Riza, for that very informative session on tool-based LCNAT. So, and thank you for the questions posted. So we will answer to them per question by email. And we have reached the end of today's webinar. I'd like to thank all our resource speaker for sharing their knowledge, and of course to our participants as well for staying up to this time. And on behalf of KNCV, we would like to thank all our collaborating partners. We would like to thank DPCB both for the DR TPT and Stool LCNAT.
NDRL.
And of course NTRL. And again, thank you everyone for attending this webinar. Have a good week ahead.